Good evening everyone. My name is Dr. K. MANJULA. Today my topic is pyogenic granuloma of lower eyelid. Aim to study and outline the management of pyogenic granuloma. Background: pyogenic granuloma is a benign lesion that occurs in the skin and mucous membrane as inflammatory hyperplasia. It is a focal reactive growth of fibrovascular or granulation tissue with extensive endothelial proliferation. It present as a sessile or pedunculated lesion with a smooth or lobulated surface. It is erythematous, bleeds easily untouched, and it is non-tender on palpation. Case details: a 50-year-old female patient from Rayachoti, Kadapa was referred to ophthalmology OPD with mass on medial aspect of left eye lower lid for the past 1 month, which started as a small blister-like lesion, gradually increased in size and attained the present state. History of bleeding with trivial injury. History of minor trauma to lower lid was present 1 month ago with goat horn. The patient's medical history was unremarkable. There was no history of any surgeries to the lower lid in the past. General examination was normal. No regional lymphadenopathy was found. On local examination, a sessile lobulated pinkish red mass of about 5 into 5 centimeters was seen on the medial 1/3 of the lower eyelid of left eye, extending onto the medial canthus. Surface is lobulated, grayish white membrane seen on the surface, soft, non-tender, irreducible, no thrill is felt on the mass and not increasing in size with Valsalva maneuver. On ocular examination, anterior segment was normal, posterior segment evaluation was normal in both eyes. Best corrected visual acuity was 6/6 in both eyes. Her blood pressure was 120/80 mm of Hg, and all other routine blood investigations were normal. On histopathological examination, it reveals a polypoidal lesion covered by non-keratinized stratified squamous epithelium with irregular acanthosis, extensive ulceration, and underlying inflamed granulation tissue. The underlying stroma was edematous with foci of lymphoplasmocystic inflammatory cell infiltrate. There was diffuse proliferation of dilated, thin-walled and congested vascular spaces in the stroma. The blood vessels were lined by a single layer of bland endothelial cells. Patient was kept on oral beta blockers, oral propranolol 0.5 milligrams per kg body weight in 3 divided doses a day for about 4 weeks, following which the mass has drastically reduced in its size and vascularity. On surgical management, radical excision of the mass followed by reconstruction of the defect done by transposition flaps under local anesthesia. Intraoperative bleeding was secured. Postoperative period was uneventful. Postoperatively, broad spectrum antibiotics and NSAIDs were given. Sutures were removed on 7th postoperative day. Thank you.